We will now begin Week 6, Mendelian Inheritance, Part 2. Please look at this inheritance pattern and say what type of inheritance that it is. As you can see, it's autosomal recessive. We have the horizontal inheritance pattern, two siblings, male and female, and their parents are not affected, but their parents must be carriers. What type of inheritance pattern is this pedigree? Take a few moments. Look at those who are affected. As you can see, it was X-linked recessive. When looking at this slide, you see that you have two males that are affected. You have females that are carriers. Both mothers of the affected males were carriers for this gene, but because it was X-linked recessive, they did not suffer from the specific disease. As we discussed earlier, in autosomal recessive inheritance, the genetic diseases that are transmitted in this mode require the mutant gene to be present in a double dose, and the affected individual then inherits one mutant gene from each parent. In the case of multiple alleles, an individual carries two alleles for each autosomal gene. The gene can have multiple alleles because its sequence can deviate in many ways, and different allele combinations can produce variations in the phenotype. The PKU has hundreds of alleles, resulting in 4 basic phenotypes, and the CF gene has over 1,500 alleles. Phenylketonuria, or PKU, is an autosomal recessive disease. It's a disorder in which the enzyme phenylalanine hydroxylase, PAH, is absent totally in the classical form or deficient in the variant form. The enzyme is needed to convert amino acid phenylalanine to tyrosine, and when deficient, an excess of phenylalanine and a deficiency of tyrosine results. Tyrosine is an important amino acid for the production of thyroid hormones, melanin, and the neurotransmitters such as dopamine and the catecholamines epinephrine and norepinephrine. This results in excessive amounts of phenylalanine in the blood and other body fluids. Some of them are metabolized by other enzymes and pathways into phenylpyruvate, which lowers the pH of the blood. And phenylalanine and phenylpyruvate are found in the urine of patients with the disease. The signs and symptoms of this disorder is a small head circumference, severe cognitive deficiencies, uncoordinated motor movement, seizure activity, tremors, growth retardation, and the skin, eyes, and hair color are lighter than those of the parents and unaffected siblings. There's also a musty or mousy odor, especially of the sweat, breath, and urine. This slide is showing the metabolic pathways of phenylalanine. You can see that if you need phenylalanine to make tyrosine, and then you can see that if you don't have the phenylalanine to make the tyrosine cannot be converted to the other products that are needed, such as thyroxine, which is your thyroid hormone, and your dopamine and epinephrine, and also you cannot make the melanin pigments. And it's for this reason that these individuals have the light hair color and light eye color. Before the causes of PKU were understood, PKU caused severe disability in most people who inherited the relevant mutations. Nobel and Pulitzer Prize winning author Pearl S. Buck had a daughter named Carol who lived with PKU before treatment was available and wrote a moving account of its effects in a book called The Child Who Never Grew. Many untreated PKU patients born before widespread newborn screening are still alive, largely though in dependent living home institutions. PKU was discovered by the Norwegian physician Dr. Folling in 1934 when he noticed hyperfetal anemia HPA was associated with intellectual disability. In Norway, this disorder is known as Folling's disease, named after him. Folling was one of the first physicians to apply detailed chemical analysis to the study of disease. What he saw was that a young woman had 2 children who had been normal at birth but subsequently developed intellectual disabilities. When the young son was a year old, the mother noticed a strong smell to his urine. Folling obtained urine samples from the children, and after many tests, he found that the substance causing the odor in the urine was phenylpyruvic acid. The children, he concluded, had excess phenylpyruvic acid in the urine, the condition which came to be called PKU. His careful analysis of the urine of these two siblings led him to request many physicians near Oslo to test the urine of other affected patients. This led to the discovery of the same substance he had found in 8 other patients. He conducted tests and found reactions that gave rise to benzaldehyde and benzoic acid, which led him to conclude that the compound contained a benzene ring. On further testing, he was able to show the melting point to be that of phenylpyruvic acid, which indicated that the substance was in the urine. Please go to the YouTube, to the link here to the YouTube about Dr. Folling. In 1961, President John F. Kennedy established the Presidential Advisory Commission on Mental Retardation. His own sister, Rosemary, was mentally retarded since birth and most likely due to brain damage at birth. And when he established this commission, they came out with a report in 1962 which advocated for newborn screening programs. This slide shows President Kennedy with his sister Rosemary, and it also shows a picture of the entire family where you can see Rosemary is standing next to her brother John, and she was the oldest daughter. PKU was the first disorder to be routinely diagnosed through widespread newborn screening. Dr. Robert Guthrie introduced the newborn screening test for PKU in the early 1960s. With the knowledge that PKU could be detected before symptoms were evident and treatment initiated, screening was quickly adopted around the world. Austria started screening for PKU in 1966 and England in 1968. The incidence of PKU in the United States is 1 in 10,000 births, and there is a carrier rate of 1 in 50 individuals. Turkey has had the highest documented rate of 1 in 2,600 births, most likely due to consanguinity. In 1963, the United States began testing for PKU, and Massachusetts was the first state to mandate screening. Today, every state in the United States does screen for PKU and for hypothyroidism, as well as many other metabolic diseases. For the treatment of PKU, individuals who have PKU are fed a diet low in phenylalanine, and this needs to begin as soon as possible after birth. Blood levels are monitored through periodic blood tests, and there's a special formula for babies which is called lofenolac. The levels of phenylalanine must be monitored throughout life to prevent mood disorders, difficulty concentrating, and other neurological problems. Originally, it was thought that they didn't have to worry about the high levels of phenylalanine once the brain had grown, but this was shown not to be true. There is a new drug which is called sapropterin hydrochloride, which is used, and it is a synthetic form of a cofactor, which is needed to make the PAH. This slide shows you the foods that are best for individuals who have PKU. So you can see that a lot of these foods aren't going to be the favorites of many children, and it is very difficult, especially when children get older, to keep them on a low phenylalanine diet. In looking at individuals who do have PKU, most of them display somewhat lower cognitive abilities than their siblings. They demonstrate hyperactive behavior, and they have what is referred to as below normal executive functions. And these include behavioral functions associated with prefrontal lobe brain activity and include problem solving, controlling impulses, planning, and making goal-directed actions. When a patient who has PKU decides to become pregnant, there is a need to control the phenylalanine levels before and during the pregnancy. The infants do not have PKU, but during the time that they are developing, they are in an environment of high levels of phenylalanine, higher than normal, and you want to keep them as close to normal as possible. There is an increased incidence of a variety of health problems and birth defects among infants who are born to women who have PKU. And most commonly, these involve the cardiovascular systems. Tay-Sachs is a lysosomal storage disease in which there is a deficiency of the enzyme beta-hexaminidase A, which results in the accumulation of GM2 ganglioside in brain cells. The gene for beta-hexaminidase A is located on chromosome 15. It is an autosomal recessive disease, and 3 specific mutations are responsible for nearly all of the cases of the classic type of Tay-Sachs disease. The incidence of Tay-Sachs disease is highest among people of Ashkenazi Jewish ethnicity worldwide, about 1 in every 3,600 births. The incidence among non-Jewish population is much less frequent, about 1 in 320,000 births. A mutation that is unrelated to the predominant Ashkenazi mutation occurs with similar frequency in families with French Canadian ancestry and has the same pathological effects. Like the Ashkenazi Jewish population, the French Canadian population grew rapidly from a small founder group and remained isolated from surrounding populations because of the geographic, cultural, and language barriers. In the early days of Tay-Sachs research, the mutations in these two populations were believed to be identical. Some researchers claim that a prolific Jewish ancestor must have introduced the mutation into the French Canadian population. This theory became known as the Jewish fur trader hypothesis among researchers in population genetics. However, subsequent research has demonstrated that the two mutations are unrelated, and pedigree analysis has traced the French Canadian mutation to a founding family that lived in southern Quebec in the late 17th century. If we look at Tay-Sachs disease among the Louisiana Cajuns, the same mutation found among the Ashkenazi Jews occurs in the Cajun population of southern Louisiana, an American ethnic group that has been isolated for several hundred years because of linguistic differences. Researchers have traced carriers from several Louisiana families to a single founder group, not known to be Jewish, that lived in France in the 18th century. At birth, the infants have completely normal appearances and reflexes, normal muscle tone, and intellectual potential. In the first few months of life, they progress normally. By 6 months, the physical development and cognitive development regress. Hallmark is cherry red spot on the macula. Over time, the muscles become weaker, and most reflexes diminish, except for the startle reflex, the moral reflex. Physical movement begins to decrease, and eventually paralysis occurs. Eventually, blindness and seizure activity happens, and most of the children die between the ages of 2 and 4. These are 2 pictures of 2 children that have Tay-Sachs disease. In this picture, you can see the cherry red spot on the macula. Before we move away from Tay-Sachs disease, I want to add a little bit more, and we will be coming back and looking at some of these diseases later. But I want to tell you about a parent who had a child who had Tay-Sachs disease, who did not know that she was a carrier, nor that her husband was. And she is of Ashkenazi Jewish descent. And her daughter, as well as her nephew, died of Tay-Sachs disease, and she founded this Courageous Parents Network. I'd like you to go to the website and to look at some of the videos, and also to look at the link to the YouTube. This network is a free 24/7 destination for families caring for children with serious illnesses. The goal was to help the seemingly impossible journey feel possible. It helps the parents connect to families courageously sharing their stories via video, podcast, and discussion. It helps the parents to learn from pediatric care providers and other experts, including genetic counselors, and to explore a wide range of topics or to focus on what they need today. Mary Frances Garber, who is a genetic counselor, is in some of the videos that are there on genetic counseling. I would like you to look at them. And also, Mary Frances will be coming to our March 3rd, March 4th weekend. She will be presenting on March 3rd, and she will be discussing what the grieving process and the palliative care and also hospice for children that have many of these genetic diseases. If we look at some of the benefits associated with being a carrier, and we will study this in more detail when we start to look at population genetics. If you carry the gene for sickle cell and beta thalassemia, it protects you from getting malaria. If one carries the gene for cystic fibrosis, it protects you against cholera and dysentery. And if one carries the gene for Tay-Sachs, we see that they are protected from tuberculosis. As I said, we will be looking at this in more detail. Please look at this slide on making predictions. If we look at this slide, we see that Tanisha's brother, Deshaun, has sickle cell disease. If we look at A. And Tanisha wonders if her fetus has inherited the sickle cell allele. First, she must calculate the chance that she is a carrier. The Punnett square in B shows that the risk is 2 in 3. She must be genotype homozygous dominant or heterozygous dominant, but cannot be homozygous recessive because she does not have the disease. The risk that the fetus is a carrier, assuming that the father is not a carrier, is half Tanisha's risk of being a carrier, or 1 in 3. Please go over this slide, and we will continue to be looking at this as we begin. In a week, we will be starting to look at the population genetics. Let's look at some X-linked recessive disorders. Some of the more common ones that we have are red-green color blindness, hemophilia A, hemophilia B, Duchenne muscular dystrophy, and glucose 6-phosphate dehydrogenase deficiency. In looking at red-green color blindness, it's a very common trait in humans and frequently used to explain X-linked disorders. Between 7 and 10% of men and 0.49% to 1% of women are affected. Its commonness may be explained by its relatively benign nature. It is also known as dautism. I myself suffer from red-green color blindness. I have a mild form, and both of my sons have red-green color blindness. If we look at hemophilia A, it's a blood clotting disorder caused by a mutation of the factor VIII gene, leading to a deficiency of factor VIII. It was once thought to be the royal disease found in the descendants of Queen Victoria. This is now known to have been hemophilia B, as I mentioned in a couple weeks ago. Hemophilia B, also known as Christmas disease, is a blood clotting disorder caused by a mutation of the factor IX gene and leading to a deficiency of factor IX. It is rarer than hemophilia A, and as noted, it was common among the royal descendants in the 19th century of Queen Victoria. If we look at Duchenne muscular dystrophy, it is associated with mutations in the dystrophin gene. It is characterized by the rapid progression of muscle degeneration, eventually leading to loss of skeletal muscle control, respiratory failure, and death. And lastly, looking at glucose 6-phosphate dehydrogenase deficiency, it causes a non-immune hemolytic anemia in response to a number of causes, most commonly infection or exposure to certain medications, chemicals, or foods. Commonly known as favism, as it can be triggered by chemicals existing naturally in broad or fava beans. In looking at X-linked dominant disorders, they're extremely rare, and for most disorders under this category of inheritance, the severity is so strong for males that the disorder is lethal and they die in utero or shortly after birth. And in X-linked dominant disorders, the affected father transmits the disorder to all of his daughters, who then express the disorder, and to none of his sons. And an affected woman generally has unaffected daughters, affected daughters, unaffected sons, and affected sons in equal proportions. The most notable feature that distinguishes this transmission from that of autosomal recessive is the complete lack of father-to-son transmission. I'd like you to look at these two diseases, vitamin D resistant rickets or hypophosphatemic rickets, which is found in males and females, and incontinentia pigmenti, again found in males and females. I'd like you to look up these two disorders as part of your work this week, and you'll be able to discuss them as part of your next exam, which will be in 3 weeks. I would now like to look at self-influenced expression. This is where a gene expresses itself differently in two sexes. For example, if we look at male pattern baldness, it's seen so much more frequently in males than in females. But it's not X-linked, as there is male-to-male transmission. In females, the allele is expressed only when homozygous. In males, the gene is manifested in both the heterozygote and the homozygote. In sex-limited expression, some sex-influenced genes only manifest themselves in one sex, in which case they're called sex-limited. One example is the autosomal dominant precocious puberty. The disorder is expressed only in males, but can be transmitted by females. X-linked can be ruled out because male-to-male transmission occurs. We are now at the end of week 6. What I'd like you to do is to complete the problem set and to submit the answers to me. I would also like you to look over the various websites and YouTube videos that I have given you. And I want to make sure that you go over the X-linked dominant disorders that I assigned for you so that you'll be able to answer them when we come to the next exam.